I'm Adam Wright, hip and knee replacement orthopedic surgeon in Plano, Texas. Today I'm talking about one of my patients. He's a 50-year-old who has kind of a complicated past history involving his hips. So he was a professional athlete and was really rough on his body. However, he also started with a childhood hip deformity. He had a disease called perthes, which means that his femoral head, or the ball, was misshapen to begin with. Plus, years of abuse to his hips and his knees resulted in multiple fractures, multiple sports injuries, to the point that he's in his 50s and he can barely walk. He's on narcotics, he can't go to the gym, he's walking hunched over because his hips don't even go straight. They hardly rotate at all, and he's just in a lot of pain. He's also fit. He needs to get back to his life. He's way too young for surgery, and a lot of times people will turn patients away because they're too young, but at a certain point, if you are losing function, you gotta get back to life. You can't be cut down in the prime of life. And so here's an example of what's going on. A lot of patients, I like to show them their good side. Well, unfortunately, he doesn't have a good side. So I could show you what a good hip x-ray looks like in a minute, but both of his are actually terrible. It should look like a ball and a socket with a space in between. And that space is made up by your cartilage. And once that starts to wear out, the ball and the socket get closer and closer together. Well, you can't see the difference between his ball and his socket because it's bone grinding on bone. And he doesn't even have a round ball anymore. It's oblong, and he's got huge bone spurs that shouldn't be there. So for this patient, he's got end-stage arthritis. There's nothing we can do. Injections won't help. Anti-inflammatories might help the pain. He's tried physical therapy, but he can't stand up straight and he can't walk. So ultimately, we decided on surgery. Now, there are lots of ways to do a hip replacement, and there's a lot of strategies for each patient. You have to take every patient individually. Why would you do it one way versus another? So I will say that my typical approach, which means how do you get to the hip, because it's deep in your body, I go from the front, which a lot of people call the direct anterior approach. There's a lot of advantages to that. Number one, you don't cut any muscle off the hip. So because of that, people recover a lot faster than traditional approach, which is from the back or from the side. I'm sending patients home the same day of surgery because of that. They're up walking within 4 hours. So for him, that's exactly what we did. And we talked about multiple options of doing it at the same time versus doing one and the other. And ultimately we decided on doing one, letting him recover, feeling better, and then going and doing the other side. So over the course of the last summer, we were actually able to replace both of his hips. We started with one and then we did the other side. And just a little bit of the anatomy of a hip replacement here. There's several pieces that are involved. So first is the stem portion. So this goes inside the femur. And a lot of people think, well, this looks like a big spike. And that makes it sound like it hurts probably more than it does. But what happens is your bone actually grows onto this metal. So then there's the socket, which is this portion right here. And the socket actually is coated in titanium that your bone grows into as well. I put some screws. That's just a style preference for me. I like to make sure that whenever we put these together that it never moves and it stays right where we put it. So I always put an extra screw or two just in case. Now, then there's two other parts to talk about. One is actually the ball. The ball can be made of several different things: metal, ceramic, and I typically use a ceramic in all of the cases that I do. And then there's a part that you can't see that's invisible on the x-ray, and that's actually a plastic liner. That goes inside the socket, and it's a very highly cross-linked polyethylene. It has a great wear record, and that's one of the more common ways of doing it. The other thing that you can put on the inside is what's called a ceramic. And so you can have a ceramic ball on a ceramic liner, and that has probably the best wear characteristics of what's available on the market right now. It has two unique problems. It can squeak and it can break because it's a ceramic, which means it's like a glass. Now, both of those are pretty rare, but they are something that you should at least warn patients about. But if you want the top of the line, I'd say that's it. One of the other things that people ask about is what's called a metal on metal hip. That's where you have a metal ball inside of a metal socket. Seemed like it was a great idea 10, 15 years ago, but we found out that that creates a lot of metal debris. So people will always ask, is this a metal on metal hip? Do you do those? And the answer is no, we don't do those anymore, at least not in our practice. One of the things people ask about a lot is what's the recovery for a hip replacement? And that depends on your functional level before surgery, I think. But my patients, we have them up and walking within 4 hours after surgery. I do ask my patients to use a walker for the first week, and that's usually because you're taking medicines that you may not have had before, and I don't want you to be dizzy and fall. Now after that, you can just go to walking like normally, and I'd say at least half my patients do come in without a cane or a walker or anything at 2 weeks. Now, some people bring in a walker because they don't want someone to run into them, and I think that makes a lot of sense too. People ask about therapy, which I think makes a lot of sense. I have home health and physical therapy coming to your house for the first 2 weeks after surgery. They're making sure you're getting up, moving around safely, and not doing anything you shouldn't be doing. After that, there's really not too much. In fact, I'm usually slowing people down. They want to go back and do activities that I think they're not quite ready for yet. But at about 6 weeks, we start letting you do most of the things that you want to do. Start, chipping and putting and maybe driving the golf ball, and then also if you're doing pickleball or tennis, starting to get out there and put those reps in and see if you're ready to start playing. The only things I hold people back a while on are skiing, taekwondo, things that are really going to stress the hip out. I don't have a firm timeline other than I want you to be ready, and so practice as much as you can before you get back to high intensity activities. Thank you for listening. Thank you for learning. I'm Dr. Adam Wright, and if you have any questions, just put them in the comment bar and we'll talk about them.